Good afternoon, everybody. We're getting ready to start the session, so if you could make your way back in, that would be terrific. My name's Josh Hare. I'm from the University of Miami. I see my co-chair making his way up. It's my real pleasure to start the session on cardiac therapy from bench to clinic, and to introduce our first speaker, Professor Bolli from the University of Louisville, who's going to talk to us on cell therapy for chronic heart failure.
Thank you very much, Josh. I'd like to thank Dr. J. Zhang and Keiichi Fukuda for inviting me and for organizing a truly superb meeting, really one of the best in memory. Thank you so much. So I'd like to give you some recent developments in the treatment of chronic heart failure. You probably have seen this slide many times. I still don't have any conflicts, and probably will remain so for a long time. So it has been a rocky road. We have gone with the introduction of cell therapy at the dawn of the third millennium. We have gone through a classic Gartner hype cycle where there was initially unbridled enthusiasm for this treatment, driven primarily by the idea that it was possible to regenerate dead myocardium. That's what really, I think, was behind a lot of this excitement. And then pretty soon we went through a tsunami of disappointment and bad news. We reached a trough. And I believe that now we are in the recovery phase, where what Gardner called the slope of enlightenment, where we are building on solid data to hopefully reach a plateau of realistic expectations and maturity in this field. So I think the worst is behind us, and I'm very optimistic that we will actually show that cell therapy has a role in treatment, although not what was initially expected. So what have we learned in the last 23 years? We learned that many, but not all, different cell types are beneficial to the injured failing heart. What by that I mean, and by the way, these are preclinical data, so I'm talking about animal data. By beneficial, I mean that if you put different types of cells in injured heart function usually improves. This is beyond question, okay? This can no longer be questioned. There are literally hundreds of papers from hundreds of different laboratories all around the world showing it. So this, I think, has been clearly demonstrated. We also learned that many so-called stem cells are not really stem cells, or at least have not been proven to be stem cells in the specific studies that have been published. By stem cells, I mean, according to the strict definition, pluripotent and self-renewing cells. So I try to avoid the S word because it's very inflammatory, and also because, honestly, most of us have never shown that the cells we are using are truly stem cells. The big revelation, the big lesson that we learned in the last 23 years is that transplanted cells, regardless of the type, it doesn't matter whether it's bone marrow mesenchymal, CD34, c-KIT positive cardiac cell, embryonic cells, it doesn't matter, do not engraft in the heart and do not form cardiac myocytes, which is the opposite, as I just mentioned, of what was initially hoped and that drove all the hype in the early 2000s. So we realized this very early on. The first clue for us came in 2010 in this paper published in Circulation. So I'm talking now about 13 years ago, where we were using c-KIT positive cardiac cells, right, CPCs. And we expected them to make new myocytes. Well, lo and behold, 35 days after transferring the CPCs into rat hearts, only 1% of the non-infarcted myocardium was EGFB positive, despite an improvement in function. So clearly, there was not enough new muscle regenerated to account for the improvement in ejection fraction. So we decided to go to the bottom of this, and we were the first lab to show that c-KIT cardiac cells do not engraft and do not make new myocytes. This paper was published in PLOS ONE 9 years ago in 2014, and we injected the CPCs into mice, either intramyocardially or intracoronarily. We measured them using an RT-PCR method that's very sensitive, where we could actually count them down to single cells. And bottom line is that after injecting 100,000 of these cells, 35 days later, there were less than 1,000 or about 1,000 left in the heart. So they were all gone. And yet, the function of the heart was improved. So at that point, we realized, wait a minute, the c-KIT positive cells don't do what everybody else was saying, or we were saying up to that point. They do not engraft, they do not become cardiac myocytes. They must work by some different mechanism. We were the first lab to point that out. So transplanted cells work via paracrine or endocrine mechanism, such as release of non-coding RNAs, proteins, lipids, extracellular vesicles. They're factories. They produce really myriads of things. And I honestly think it will not be possible to pinpoint which of these factors is responsible for the beneficial effects. Nature is always infinitely complex, and I think if we spend time trying to identify the factors, it will take our lifetime or longer. So the precise nature of these mechanisms is still unknown. The hypothesis is that these paracrine factors, exosome and things like that, are anti-inflammatory, anti-fibrotic, anti-apoptotic, angiogenic, but the short answer is that we don't know how exactly the paracrine mechanisms work in repairing the heart. Now, the other thing we learned, and we did a lot of work on that, which I don't have time to show, is that because cells disappear rapidly, within a few weeks, as I just said, repeated dosing may enhance the therapeutic actions of the cells. Okay, how about in the clinical world? So there are many studies in heart failure. I don't have time to summarize them, but I want to point out one study that I don't think has achieved or has received the attention that it should have received. That's the CONCERT-HF trial that was published 2 years ago in the European Journal of Heart Failure. So this was a phase 2 randomized, double-blind, placebo-controlled, multi-center trial of the NHLBI CCTRN to investigate the feasibility, safety, and efficacy of autologous bone marrow, MSCs, and cardiac c-KIT positive cells, or CPCs, in patients with heart failure caused by ischemic cardiomyopathy. The oversight was unbelievable. I mean, we had layer after layer after layer of oversight, not just the NHLBI, but of course all the IRBs, the DSMB, the FDA. I mean, it took us 4 years just from the time we started to discuss the protocol to the time we started enrolling patients, just 4 years to go through all these regulatory and administrative oversight. And I would argue that this was one of the most rigorous, if not the most rigorous, trial of cell therapy in heart disease to date. So there were 10, this was 10 years of work from conception to publication, 10 years of work by 7 centers, 2 cores, a biorepository, a GMP facility in Miami, the data coordinating center, and of course the NHLBI. So very quickly, we enrolled 125 patients with ischemic cardiomyopathy. The average ejection fraction was 29%. And the patients were randomized to 4 groups, 1-to-1 to 1-to-1, either the combination of mesenchymal cells and CPCs, c-KIT cells, or MSCs alone, CPCs alone, or placebo. The cells were delivered by transendocardial injection. So technically, the study was negative because the primary endpoint was ejection fraction, and there was no significant difference among groups, nor was there a difference in scar size or exercise tolerance, or 6-minute walking distance, or BNP levels. However, when you study a new therapy, things pop up that are not expected, because the bottom line is that we are still learning what cell therapy can or cannot do, right? So we start a trial with a certain primary endpoint, and then we find out something else actually shows an efficacy signal that maybe was not expected. So one of the pre-specified secondary endpoints of CONCERT was the occurrence of heart failure MACE, which means major adverse cardiac events, which means the combination of hospitalization for heart failure, exacerbation of heart failure not requiring hospitalization, just IV therapy in the emergency room, or death from any cause. So one of those three events is a heart failure MACE. So using the most rigorous method, which is the intention to treat analysis, okay, that's the way, the most appropriate way to analyze data, what we found was that the incidence of these events at 1 year after cell therapy was significantly reduced in patients who received CPCs from about 28 to 6%, not in patients receiving MSCs, mesenchymal stem cell alone, but it was also significantly reduced in patients receiving CPCs plus MSCs, suggesting that CPCs are driving this reduction in MACE. So if we break down MACE into the three components, you see that most of this benefit relates to a dramatic drop in hospitalizations for worsening of heart failure. Well, somebody may say this may be just a fluke, right? A statistical fluke. So let's look at the analysis of data as treated. So this is a different way to look at the results. This is looking at the data based on what patients actually received, not intention to treat, but as treated. And it turns out when you do this, there were 15 patients who were never treated because of different technical reasons. Cells would not grow, or cells went bad during shipment, or something happened. So these 15 patients were not treated, but were followed like all the others. Well, what happens to these 15 patients? This group here that you see has the same incidence of MACE as the placebo patients. Is that interesting? So it's about 33 versus 26. And so now you have three groups that have similar incidence of MACE, right? You have patients who never got anything, you have placebo patients, and you have patients receiving MSCs alone. In contrast, the two groups that received CPCs, c-Kit cells, both of them have a significantly lower incidence of MACE. So people may say, well, that's just a coincidence. Maybe, I don't know, but it would be really a very, very unlikely coincidence that 5 groups, all of them behave according to this interpretation. So this is just a graph of the hazard ratio showing that in patients receiving CPCs alone, there was an 80% reduction in the risk of one of those three events I just told you. And in patients receiving both cells, there was a 75% reduction. So we also looked at the quality of life measured by the Minnesota Living with Heart Failure questionnaire. Remember, the lower the score, the better. And in this case, the only groups that were improved were the groups that received the combination of CPCs and MSCs, both at 6 months and at 12 months. So the CONCERT trial suggests that in patients with chronic ischemic heart failure, remember, these are patients on maximal guideline-driven therapy. They're getting the best possible treatment available in 2020 or wherever they were enrolled. A single administration of autologous CPCs or MSCs has measurable beneficial effects over the ensuing 12 months, namely a reduction in hospitalization for heart failure with CPCs and improvement in quality of life with MSCs. The best overall results were obtained by combining MSCs with CPCs with a reduction in the MACE hazard ratio of about 75%. Neither CPCs nor MSCs, however, improved ventricular function or reduced scar size. So this may sound kind of strange. right? A little counterintuitive. But if you look at the literature, this is not the only trial that shows a reduction in MACE after injection of cells in heart failure patients. There are 2 other double-blind, randomized trials showing also a reduction in MACE after a single injection of cells. The Excel DCM trial, published in The Lancet in 2016, showed a 37% reduction in MACE, and DREAM-HF, which is the latest trial, showed a 30% reduction. So this seems to be a pattern, and although we don't understand exactly how this happens, the data are the data, right? So we don't understand why statins are beneficial in patients with acute coronary syndromes. It's a class 1A recommendation for physicians, right? ACCHA guidelines, class 1A, statins for ACS. Nobody has any idea why they're beneficial, but they are, okay? So that did not stop us from using statins, right? So we should try to figure out the mechanism, but these are the data. There is, after one single injection of these cells, a 70% reduction in hospitalization for heart failure in concert. So DREAM-HF is the largest cell therapy trial to be conducted to date. It was just published in JACC in February. 580 patients, randomized, double-blinded. These are bone marrow mesenchymal stromal cells injected transendocardially in heart failure patients. Patients were followed for 2.5 years. So overall, there was, interestingly, a reduction in death, myocardial infarction, or stroke by about 40%. This is 2.5 years after a single injection of these cells in the heart. The important message of DREAM, though, and I go back to my original message, we are still learning how these cells are working. When they separated patients, so they found this reduction only in patients who were inflamed, meaning high sensitivity CRP greater than 2.0. Those are patients who have systemic inflammation. In patients who are not inflamed, which are these on the right side, I don't know if you can see them, there was no significant difference. So clearly, the responders were patients who had systemic inflammation in DREAM. Same thing for left ventricular function. There was an improvement in ejection fraction only in inflamed patients with CRP greater than 2.0, no improvement in patients where CRP was less than 2. So what have we learned in the last 23 years in heart failure? First of all, administration of adult cells is safe. There has never been a single adverse event. To the dismay of the enemies of cell therapy, to their dismay, there has not been one single adverse event that's ascribable to cell therapy in itself. There have been complications due to the delivery of cells, perforations, things like that, but not to the cell product in itself. It's, I don't have to get into this, but a major disappointment has been the failure of these cells to do anything good in patients with acute infarction in STEMI. There are now 10 trials, at least, probably more. The last one was BAMI, which was really the death knell for cell therapy in STEMI. Bottom line is that cells are not beneficial in patients with STEMI. There are very promising data in refractory angina. I wish I had time to get into that, but I don't, but they're very encouraging. In chronic heart failure, as I just showed you some examples, DREAM-HF, CONCERT, EXCEL, DCM, there are randomized, double-blind, placebo-controlled phase 2-3 data suggesting beneficial effects of these cells at 1 year or longer. In the case of DREAM, was 2.5 years after treatment. Now, what's interesting is that we see this signal for efficacy despite the fact that we're still learning how to use cell therapy, right? We don't know what is the optimal type. We don't know what is the optimal dosage, the optimal route of administration, or the number and frequency of administration. So despite all of this uncertainty, we are seeing a signal. That, to me, is actually the most amazing thing, that we are seeing a signal for efficacy despite the fact that we still don't know how to use this treatment. So despite these encouraging results, the field of cell therapy has come to almost a screeching halt in recent years due to lack of federal funding. So the situation became so dire that Dr. Bromwald decided to write an editorial last year in the European Heart Journal. And he called me and we discussed this at length before he published this editorial. And we had a very good interaction. And the editorial was very good. Basically, Dr. Bromwald is saying a call for action. We need to start looking at this treatment because that's the only way forward, right? Try to figure out whether there is these beneficial effects can be confirmed with larger, rigorous trials. So what is needed to move the field forward is rigorous, well-designed, randomized, double-blind, placebo-controlled clinical trials to conclusively address efficacy. And it's important to have an open mind, to avoid preconceived notions, and to let ourselves be guided by the evidence. Now, in the last next couple of minutes, I want to show you something new that I think may change completely the field of cell therapy, which is the intravenous delivery of cells in heart failure. Why intravenous? Well, I just showed you cells do not engraft, so I don't like the term regeneration. I don't think we are regenerating. I like the term reparative therapy, right? Not regenerative therapy. The progressive deterioration of left ventricular function in heart failure is caused at least in part by persistent systemic inflammation resulting from the activation of the immune system and causing infiltration of the myocardium by inflammatory cells such as monocytes. We know the cardiosplenic axis, immune cells trafficking between the spleen and the heart and infiltrating the heart. And we also know that intravenous infusion of mesenchymal stromal cells exerts systemic anti-inflammatory and immunomodulatory actions. We know this from many disciplines outside of the heart, okay? Graft versus host disease, ulcerative colitis. There are tens and tens of studies showing this. So we did a study in a rat model of chronic ischemic cardiomyopathy where we gave 3 injections of either vehicle mesenchymal stromal cells from bone marrow, cardiac mesenchymal cells, or c-KIT positive cells, 1 month apart, and then we followed up the hearts. These were rats that had a chronic scar after an infarction. And very briefly, at 1 month after the first dosage, we see a benefit, a trend for a benefit, but it's not really significant. But after the third dosage, okay, 1 month after the third dosage of cells, we see a significant improvement in ejection fraction with all 3 cell types. That's another way of looking at the same data, looking just at the bone marrow MSCs. The first treatment produced an improvement, but not so great. But by the time you give the third dosage, we see a very handsome therapeutic effect of these cells. So decide to move this to a large, and the next step, which is a pig model of chronic ischemic cardiomyopathy, big infarction, 1 month of recovery, so now you have a stable scar. And then we do the same thing we did in rats, 3 dosages intravenously, okay? 2 million bone marrow mesenchymal stem cells, stromal cells per kilogram, 1 month, 35 days apart, and then the pigs were sacrificed. So there was no effect on scar size or ventricle, no reduction in scar size. We did serial echocardiographic studies. This was like a 4-year effort to do this study. It was really an enormous effort. And we did the echo baseline before the first treatment, before the second, before the third, and then at the end of the study. And so here are the results of the echocardiographic analysis. At the end of the study, after the third treatment, there was an improvement in ejection fraction with both a single dose in red and 3 doses in orange. Although the improvement tended to be a little greater with 3 doses, and if we look at the change in ejection fraction, same pattern, improvement with 1 and 3 doses. Then we use MRI at baseline and the end of the study. This shows one of the infarcts in these pigs, and that's an example of how we measure ventricular volumes by MRI during the study. And so we saw by MRI in the vehicle group, in this case, the ejection fraction actually decreases, single dose improves, and repeated doses improves even to a greater extent. The data are summarized here at the end of the study. The only group that showed a significant improvement in ejection fraction was the repeated dosage group. shown also as the change in ejection fraction, whereas the single dose was not significantly different from vehicle. We measured LV strain by MRI, and again, the radial strain improved only in the repeated dosage group, not in the single dose group. Finally, we did hemodynamic assessment of the ejection fraction using the pressure volume loops, which is the actually gold standard for measure ventricular contractility, and the results were the same as MRI. The only group that showed an improvement in ejection fraction was repeated dosage, whereas single dose did not show any effect. We measured not only ejection fraction, which is load dependent, but also end systolic elastance, which is load independent and is considered the gold standard for measuring ventricular function. So as you know, this elastance is measured by the slope of the end systolic pressure volume curve. If you look in the vehicle group, the pre-treatment curve in blue gets worse in red at the end of the study, meaning the slope is decreased, indicating a decrease in contractility. After repeated dosages, it's the opposite. The pre-treatment is in blue, gets steeper, the slope gets steeper after 3 dosages, indicating an improvement in ventricular contractility. This statistical analysis shown at the bottom again. The elastance improved only with 3 dosages, but not with 1 dose of cells. We did a picroseries analysis to measure tissue fibrosis. We found a reduction in collagen in the non-infarcted region. This is the non-infarcted region, not the ischemic. The non-infarcted region only with 3 dosage of cells, not 1 dose. We measured the cross-sectional area. We saw a reduction in hypertrophy, only actually both single and 3 doses, but the reduction was greater with 3 doses than 1 dose of cells. And intriguingly, we found an increase in macrophages in the non-ischemic zone and border zone of these pigs. We still don't quite understand what that means. We presume these are reparative macrophages, but we are still doing histological analysis. And that only happened with 3 doses of cells, not 1 dose. So in a porcine model of chronic ischemic cardiomyopathy, intravenous infusion of either 1 or 3 doses of allogenic bone marrow-derived mesenchymal stromal cells improves left ventricular systolic function as assessed by 3 independent methods. 3 methods, not 1, 3. MRI, echocardiography, and hemodynamic studies. The salubrious effects of MSCs are more pronounced after 3 doses than after 1 dose, supporting a cumulative effect of repeated doses, similar to our finding in rats. 3 doses of MSCs, but not 1, result in decreased myocardial fibrosis and hypertrophy and increased macrophage infiltration in the non-infarcted region. So taken together, the results in rats and pigs demonstrate that intravenous infusion of MSCs are beneficial, first result. Secondly, they have a cumulative effect. And these results provide a rationale for testing the efficacy of repeated intravenous infusions of bone marrow-derived MSCs in patients with heart failure secondary to ischemic cardiomyopathy. So we were very happy to receive a funding from the Department of Defense for a phase 2 trial of intravenous infusion of mesenchymal stromal cells in patients with ischemic cardiomyopathy. The study will start in a few days. It will be a randomized, double-blind, multi-center study, and we are very excited about conducting that trial. Intravenous delivery could be a game changer, right? It's simple, inexpensive, safe, can be performed almost everywhere, in almost all patients with heart failure, even as an outpatient procedure. Importantly, it is exquisitely suitable for repeated infusions, unlike the transendocardial injection that can only be done 1 time. Basically, practically only 1 time. So our working hypothesis is that the beneficial actions of MSCs are mediated by their anti-inflammatory and immune modulatory properties, and that intravenous infusion of these cells reduces myocardial inflammation and augments a population of reparative antifibrotic and anti-inflammatory macrophages in the heart. I'd like to thank the CCTRN for the CONCERT trial and the collaborators at the Institute of Molecular Cardiology for the pig and rat studies, particularly Dr. Tang, that conducted all the rat and pig studies. Thank you very much.
Okay, in the sake of time, we're going to pass with the next speaker. Our next speaker is Dr. Joshua Hare from University of Miami. He changed the topic of his talk. So today he's going to talk about dilated cardiomyopathy and hypoplastic left heart syndrome.
Thank you very much. Again, I just wanted to thank Jay and Keiichi for an incredible meeting. I think this meeting has really set the tone for a new wave of enthusiasm in investigation and clinical trials with new products. What was my title? Okay. Yeah. So I want to continue on the theme of clinical trials that Roberto initiated. The main point I want to make in my talk is that. And if I could impart any kind of guidance to people who are planning trials now, is pay attention to the underlying disease you're studying. You cannot lump all patients together. So what I want to address today specifically is non-ischemic dilated cardiomyopathy and congenital heart disease with single ventricular syndromes. And the way our group has approached these is to look at these specifically and individually. And by doing that, we've been able to glean some important insights. These are my disclosures. So let's just jump in. Everybody should be aware that the DREAM-HF study, which did not meet its primary endpoint, enrolled both ischemic and non-ischemic cardiomyopathy. And they had about 45% of the study was non-ischemic cardiomyopathy, so it was close to 50-50. Now, I think that might have been an unfortunate decision. Ischemic cardiomyopathy is not one disorder. It has a final common pathway, which results in a large globular ventricle. You could see from this autopsy heart that there's no scar tissue in that ventricle. So it's a disease of the myocytes or the interstitium. And it's not one disease. Approximately 40% of patients with non-ischemic cardiomyopathy have an underlying genetic defect, and the large component of causality in the other group is immunologic derangements, which could or could not be due to an antecedent viral infection. We were fortunate to be able to do a study funded by the NHLBI called the Poseidon DCM study, and in the study we elected to study DCM patients separately from ischemic cardiomyopathy. And what we did in this study was we randomized patients to get allogeneic or autologous therapy, and ejection fraction was the primary endpoint. And what you could see, which is different from ischemic cardiomyopathy, is that there is a very profound increase in ejection fraction of about 8 units, which was better in the allogeneic than in the autologous. And, but there's also a very large spread. So if you look in the right panel, you could see in the individual data that about 50% of the patients who are having allogeneic cell therapy their ejection fraction at follow-up is above 40%. That's something we now term heart failure with recovered ejection fraction, and that portends a very good prognosis. So in this study, there was a responder group and a non-responder group. Here's an example of a responder. This individual had an EF of 19% and an EDV of 256 ml, so a very large ventricle. And a year later, after single treatment, added to best conventional therapy, the EF's gone to 43%, and there's been a marked reverse remodeling. You could see this nicely if you just look at the responder and non-responder group. You could see that the super responders, if you will, have EFs going up almost 15 points. So these are the group that have heart failure with recovered ejection fraction, and then there's a group that's not responding. The responder group has a very marked reduction in LV systolic and diastolic function. So what is the, were we able to learn anything about who the responder group and the non-responder group was? Well, we knew going into it that 40% of patients have genetic causes of dilated cardiomyopathy. There's a large number of genes that are implicated, and many of them affect the contractile apparatus. When we did the study, we did We were aware of this, and we consented patients going into the study to give us a DNA sample, and that enabled us to retrospectively, but prospectively planned, genotype all of the patients. And we were able to separate patients into a group that had no variants of implication for dilated cardiomyopathy, and then two other groups, a group that had variants of certain significance and variants of uncertain significance. And our hypothesis was that the genetics would play a role in the responder versus non-responder group. And indeed, our hypothesis was borne out by the data. We were very pleased to see this, that the group that had no genetic defect had the very profound increase in ejection fraction. The group that had a variance of certain significance were clearly a non-responder group and even had a trend to a decline. And then the variants of uncertain significance, which were the largest group, had an intermediate response but was still significant. So you could see how lumping all of these patients together and then lumping them with an ischemic cardiomyopathy can really have a regression to the mean effect, and you're missing your responder group if this is borne out. So unfortunately, the DREAM-HF would have missed this effect if it is in fact correct. This is hypothesis generating at this point. We looked at other endpoints. We looked at Minnesota with a Living with Heart Failure questionnaire, New York Heart Association. These are quality of life, and this corresponded to the EF changes that the greatest improvements were seen in the groups that had no pathological variants. And then finally, I think Roberta made this point, which is very important. At the end of the day, with any new therapy, no matter what it is and what the hypothesis is, you're looking for clinical endpoints, particularly in congestive heart failure. It doesn't matter if you can improve somebody's ejection fraction if they're not going to have a clinical response. There must be a clinical response. And here we saw the clinical response. The same endpoints that Roberta already alluded to. Heart failure MACE had a very poor outcome in the patients with a genetic defect in the red line, and had a 0 MACE rate in the patients with no variants. And this was also borne out in the mortality. There was 0 mortality in the group that had no genetic defect. So this data, I think, really speaks to the fact that if you have a genetic defect in your contractile apparatus or some other structural gene, you're unlikely to be able to respond to this kind of therapy. We were very fortunate to be able to continue this work because, of course, when you get a hypothesis-generating result like that, you need to be able to prove it in a subsequent study. And we have been funded to do a study we're calling Poseidon DCM2, whereby it's properly powered study of 136 patients. All of the patients are genotyped prospectively and then stratified, randomized into the 3 groups, absence of any variants of uncertain significance, and pathogenic likely variants. My colleagues at the University of Miami who are assisting in this are Bob Meyerberg and Raul Matrani, and we're in the midst of enrolling in this study. Now, I agree with the comment that Roberto made in the last talk that immunology and inflammation plays a very large role, and we did measure inflammatory cytokines in the Poseidon DCM study and noted very substantial declines in TNF-alpha levels that were greater in the allogeneic group than in the autologous group. So as we think about the advantages of using allogeneic therapy, which is off-the-shelf therapy, it appears to have a greater suppression of inflammatory cytokines than autologous bone marrow mesenchymal stem cells do. So that I think is an exciting finding, and I hope the investigators in the field will keep that in mind as they plan a new wave of phase 3 studies. Another disorder that we've been particularly interested in addressing is congenital heart disease. As I describe hypoplastic left heart to you, for those of you who are not familiar with the syndrome, you'll see that this really is a prototypic syndrome that needs to be tackled by some kind of regenerative therapy because patients with a single ventricle disease do not respond to traditional heart failure medications. The hypoplastic left heart syndrome is a devastating syndrome where children are born with a single ventricle, only a right ventricle, as everybody can imagine, that is not compatible with life, and it must be surgically corrected by a three-staged operations. The first one that's done in the first week of life, called the Norwood procedure, where the ventricle, the right ventricular chamber, is reconfigured to pump blood out of the aorta rather than the pulmonary artery with which the children were born. Let's see if this is. Can't figure this out. So yeah, the children are born with a diminutive left ventricle and a diminutive aorta. Obviously, the normal chamber has a right ventricle and a left ventricle, and the child would die once the shunting from right to left ends in the neonatal period. Even with the surgery, so this was uniformly fatal. With the surgery, the children now live into teenage years, typically not into adult years, so they get an additional 15 years of life. But the mortality, the transplant-free survival to age 15 is only 50%. And this is an ultra-rare condition affecting only 1,000 babies a year in the United States. So the initial surgery requires the construction of a neo-aorta, a transection of the pulmonary artery so that the right ventricle now pumps out to the new aorta, and then subsequent surgeries have to reshunt blood from the systemic circulation directly into the pulmonary artery here. You could see that this is the results from a study called the Single Ventricle Reconstruction Trial that was published in the New England Journal of Medicine in 2010, and you could see, even in the modern era, that the 4-year mortality is about 40% in these kids, even with the reconstructive surgery. So the reason for that mortality is that right ventricle fails in the systemic circulation. It's not capable of pumping with the systemic pressures, the loads of the systemic circulation. And so those ventricles need a boost, leading to the hypothesis that cell-based therapy might help these children. And cell-based therapy can be very conveniently delivered to these children at the time of any one of these surgeries, because the surgeon is in the chest on 3 separate occasions. So what we've been doing in a study called the ELPA study is injecting allogeneic mesenchymal stem cells into the right ventricle at the time of the second surgery, which is done at 4 months. So what is the impact on the ventricle of these reconstructions? There are excess loads imposed upon the right ventricle by virtue of it being placed in the systemic position. And there are 3 measurements that are typically used clinically. One is you see a decreasing right ventricular ejection fraction because of the load, an impaired global longitudinal strain, and an increasing amount of tricuspid regurgitation because of the ventricular dilatation. Each of these 3 measures is a direct correlate of poor outcomes. So children who have a low ejection fraction that dips below 40% are the ones who are most likely to have an adverse outcome. This is a study that's been undertaken by a company I'm a co-founder of called Longeveron, and I'm going to show you the results of a study that were just published. And there is also an ongoing study called the ELPIS II study that's enrolling 38 patients in a standard of care controlled trial with 8 centers in the United States. So the control is standard of care. The FDA did not want us to inject a placebo into these babies' hearts. So it's just standard of care versus intracardiac injection of the allogeneic mesenchymal stem cells. Now, there's quite a significant rationale. It's always difficult to study children, as I think everybody is aware, but we were able to persuade the FDA that this was reasonable to do based on all of the adult data we had, which has been presented in the last 2 talks. We presented to them that 8% increase in ejection fraction from the Poseidon DCM trial, and that was very influential in the decision for them to allow us to go ahead. So these are the study results. It was just published about a month ago, and you can see we use cardiac MRI again. We're used to seeing MRIs in adults. This is a 4-month-old baby. You can see there's one ventricle. The left ventricle is diminutive, and this child has had to undergo a Norwood procedure for that right ventricle to pump blood out into the aorta. So remember, there are three measures of poor outcome. One is tricuspid regurgitation, the other is ejection fraction, and the other is global longitudinal strain. And here are some of the data from the paper. We were very, very gratified to see that after injection of the cells, followed by MRI over a year, there is a progressive decline in the tricuspid regurgitation as opposed to a worsening. And this is potentially a positive surrogate finding. Now, if we look at the ejection fraction and the GLS data, unfortunately, there's no control group in this study. This is just from the phase 1 study, but the results are encouraging to us. So first of all, you always get a decline in the ejection fraction when you shift the ventricle from pumping into the pulmonary artery now into the aorta. But what we're looking for in the study is if it dips below 40. If it dips below 40, then that's bad. And what we were very pleased to see that there is a dip from time 0 to 6 months, but then that levels off, or in some cases starts to go back up. And that's exactly the same pattern we see in the global longitudinal strain. It gets worse initially, getting less negative, and then it starts to recover into the second 6 months of follow-up. So as a result of this data, we are conducting a 38-patient trial. That trial is in the midst of enrollment, and I hope to have the data and to be able to present that data of a control group comparison at an upcoming meeting. Now, one of the things that was very exciting was we enrolled the first group of patients, the ELPIS-1, into a long-term follow-up. We've made the point, I think, at this meeting over and over again that you really need to have a clinical endpoint. And we were able to compare the outcome of the patients treated in the ELPIS-1 with the historical control data from the SVR trial. This is the data from that New England Journal of Medicine paper, which is pretty current data. It was published in 2010. And you could see the 5-year mortality in the SVR trial is about 80%, and it was zero mortality in the 10 patients who were enrolled in the ELPIS-1 study. So of course, in the absence of a control, we view this data with caution, but it's certainly encouraging and exciting, and I think warrants the fact that this should be pursued. Again, to remind you that children do not live into adulthood. They do die from heart failure, and they do not respond to conventional heart failure medication. So this is a real area of unmet need. So I'll just summarize by saying, as we go forward, the field needs to really consider individual patient factors. You could really have a misleading trial if you fail to do that. Non-ischemic cardiomyopathy has a diverse spectrum of etiologies that involve genetic defects and immunologic disorders, and it's, I think, very important to build into future trials not just separation of ischemic and non-ischemic, but actually genetic testing. Congenital heart disease is a very important potential target for regenerative medicine, particularly univentricular diseases. A new wave of trials is underway that will further refine understanding of the application of cell-based and other regenerative therapies for non-ischemic cardiomyopathies, and trial design with clinical endpoints is essential for the application of regenerative therapies. I just would be remiss if I didn't thank all of the incredible investigators who have contributed to this. The Poseidon DCM2 centers are, as shown here. This is actually a subgroup of the CCTRN. The CCTRN was 7 centers that was together for about a 9-year period, and 4 of us stayed together to do the Poseidon DCM2 trial, Texas Heart, Roberto, Stanford, and ourselves at the University of Miami with the MRI core run by Joel Lima. The ELPIS-2 centers, the children's centers, are listed here. You can see we've got a very, very prominent group of pediatric cardiac surgeons who are expert at the hypoplastic left heart operation, all contributing to this study. And finally, thanks to Longeveron, the company that is making the product for that study. So I'll just end by thanking my laboratory at the University of Miami. None of this work could have been done if it wasn't for very, very important funding from the NHLBI going back to 2005. And I want to specifically thank Denny Buxton, who's in the audience, who we've been together on these programs going back to the Specialized Center, which started in 2005. This was an incredible program that funded centers to do animal work for the first 2 years, and then with the goal of getting INDs. So these first INDs that we were able to develop for cell-based therapy came out of the Specialized Center mechanism. The CCTRN was in existence for 3 iterations, I believe a total of 17 years, and another mechanism was the production assistance for cellular therapies, which allowed centers to learn how to make cell products and develop GMP capability in the United States. So the NHLBI has just played an incredible role in getting this field to be where it is now. Of course, we're all here because of the PCTV as well, another program. And finally, the current trials are being funded by the CDMRP program, and the ELPIS II study is another NIH clinical trial grant. So thank you very much. If there's time, I'll be happy to answer some questions.
Yeah, we can do one question, but fast, please. Only one.
Thank you. That was a really interesting talk. I'm really excited actually about your findings that the genetics make a difference to the patient response. What I was a little unclear about though was you seem to clarify it very much as in those who have variants and those who don't, so there's a difference in response. And I wondered if you could just break that down a bit more, because presumably the ones who don't have variants, they just don't have pathogenic variants that we're aware of.
Yeah, well, I think the presumption, I mean, we presume that there's a group of patients with dilated cardiomyopathy that do not have a genetic defect, that it's environmentally caused, either due to inflammation, viral infection, or a toxin. So, you know, the recognition that DCM is a genetic disease is new. It was only recognized in the 80s that there were familial variants, and then as genetic work was done, we've uncovered more and more and more different variants. So presumably it's finite, and at some point there will be a group that doesn't. We have banked all the DNA, so we are capable of doing in the future whole genome sequencing if that is warranted as knowledge evolves.
Right. No, I was just thinking about the variant negatives are probably sort of a number of variants that predispose them to getting the sort of autoimmune or the viral-mediated disease.
Right.
So it's just, it would be really interesting to break that down further. It's great that you have that DNA that we can do that in the future.
Well, we're going to have this 136 patient study now with a complete repository of, I should mention that there's been a lot of discussion about peripheral factors and endothelial function. In the new study, we're measuring a complete panel of inflammatory cytokines as well as endothelial function and circulating EPCs. So we're doing our best to get as much personalized patient information as we can in that study.
Great, thank you.
Thank you so much.
Okay, so our next speaker is Dr. Yoshida from Kyoto University, who is going to talk to us about generation of cardiac cells and tissues from iPS cells for biomedical applications.
So first of all, I'd like to thank the organization team and Dr. Jay Zhang and Dr. Keiichi Fukuda to providing me such a fantastic opportunity to provide our recent research here. So I'd like to start my presentation. So this is the COI. So we are working on the iPS-derived cardiomyocyte. So especially regarding the cardiomyocyte maturation and the cell cycle activity. So I'd like to talk about the recent progress of these topics. So let me start with the first topic, cardiomyocyte maturation. So iPS-derived cardiomyocyte is known to be a very immature phenotype, similar to the embryonic cardiomyocyte. So, during the process of the cardiomyocyte maturation, there are many differences in the sarcomere structure or calcium handling or energy production or electrophysiology. So especially we focused on the isoform switch of the troponin I. So in immature cardiomyocyte, troponin I1 is a dominant isoform. However, in adult cardiomyocyte, troponin I3 is dominant. So, to take advantage of this isoform switch of troponin I1, we generate the double reporter iPS cell line, so in which the troponin I1 expression is monitored by the expression of the GFP, and the mCherry expression is regulated by the troponin I3 expression. So using this iPS cell line, we can monitor the degree of the cardiomyocyte maturation. So using this monitor reporter iPS cell line, we conducted the high throughput screening. So among the more than 10,000 chemical compounds, we have identified several compounds which can upregulate the expression of the troponin I3 and mCherry. So among the 8 hit compounds, we focused on the 2 compounds. One is the ERR gamma agonist, and the other is the SKP2 inhibitor. So the treatment with these compounds or a combination of both significantly upregulate the expression of the troponin I3 mCherry. So, and we also confirmed the treatment of these compounds increase the expression level of the troponin I3 at protein level. And the PatchClamp analysis, we confirmed the significant increase of the action potential activity and Bmax, so suggesting the increased electrophysiological property of the iPS-derived cardiomyocyte after treatment of the such compound. And we also conducted the flux analyzer to evaluate the mitochondrial function, so that we confirm the mitochondrial basal respiration and maximal respiration and ATP production capacity is increased by the treatment of the chemical maturation inducer, including the ERR gamma agonist. So, and we also investigated the microstructure by the electron microscopy. So, so we checked the structure of the iPS-derived cardiomyocyte after treatment of the chemical compound, and we confirmed the sarcomere structure and the mitochondria structure become mature phenotype. So that we confirmed the sarcomere length is increased by the treatment of the chemical compound, and also that we confirmed T-tubule formation is induced by the treatment of the ERR gamma agonist. So now we are try to generate the mature 3D tissue, mature engineered cardiac tissue, so that we confirmed the maturation induction by the combination of the ERR gamma activation and the mechanical stretching. So we confirmed the both combination of the both induce the increased cardiomyocyte size or increased cellular alignment in engineered heart tissue, and also the sarcomere length is significantly increased, and the contraction force is also increased. And also that we confirmed mitochondrial DNA content is significantly increased by the treatment of the ERR gamma activation and the mechanical stretching. So, we are now conducting the disease model such as the hypertrophic cardiomyopathy using such a mature engineered cardiac tissue to see the difference caused by the mutation, sarcomere mutation. Okay, so next I'd like to talk about the cell cycle activity. So, so far we have conducted the cell transplantation experiment to develop the cardiac regeneration using the iPS-derived cardiomyocyte. So, from this previous study, what we have learned is number one is the graft growth with transient activation of the cell cycle activity in 3 months after transplantation. And number two is after engraftment, iPS cell cardiomyocyte undergoes in vivo maturation. So current problem is limited engraftment of the transplanted cardiomyocyte, and our question is, does the cell cycle activity of iPS-derived cardiomyocyte affect the growth of the graft? So to address these questions, we established the cell cycle monitoring system, so that we established the Fuji expressing iPS cells. So that in Fuji expressing iPS cells, the cells in G0 and G1 phase, these cells express red, Fuji red fluorescence. On the other hand, the cells in SG2M phase express green fluorescence. So in iPS cell line, the cell cycle is activated, so the many cells express green or colorless red. But on the other hand, the cardiomyocyte, most of the cells cell cycle activity is inactivated. So this cell shows the red fluorescence. So this is the picture of the iPS-derived cardiomyocyte, so that you can appreciate the most of the cardiomyocytes show the red fluorescence, and some cells express green fluorescence. So this is the movie of the iPS-derived cardiomyocyte. So that most of the cells have inactive cell cycle activity, and these cells show the red fluorescence. However, some cells still have the active cell cycle activity. So these cells show the green fluorescence, and they turn into the red fluorescence and go back to the green fluorescence. So, based on the color of the, we can determine these cells have active or inactive cell cycle activity. So, in undifferentiated iPS cells, most of the cells have very active cell cycle activity. However, during the process of the cardiomyocyte differentiation and maturation, most of the cells have become inactive cell cycle activity cells. So these cells express red fluorescence, finally. So we transplanted which expressing cardiomyocyte into the mouse heart. So 2 weeks after transplantation, some cells express Fuji green fluorescence, and most major part of the transplanted cardiomyocyte shows the Fuji red cardiomyocyte, Fuji red fluorescence. And 3 months after transplantation, so you can see most of the transplanted cardiomyocytes show the red fluorescence, suggesting that most of the transplanted cardiomyocytes finally have inactive cell cycle activity. So, so this is a picture of the transplanted cardiomyocyte. So, and we also confirmed cell cycle activity is transiently activated during the first 2 weeks and 1 month. And finally, they turn into the undergo the inactivation of the cell cycle activity 3 months after transplantation. So we sorted the red cardiomyocyte which red cardiomyocyte and which non-red cardiomyocyte. So red cardiomyocyte, most of the cells should have the inactive cell cycle activity, and the non-red cardiomyocyte, most of the cells have active cell cycle activity. And we transplanted red cardiomyocyte and non-red cardiomyocyte and check the engraftability of these cells. So because these iPS-derived cardiomyocyte also express luciferase, so we can evaluate the engraftability by bioluminescence assay. So we confirmed significant increase of the engraftment ratio in non-red cardiomyocyte, suggesting the transplantation of the cardiomyocyte with active cell cycle activity have a higher remuscularization capacity compared to the cell cycle inactive cardiomyocyte. So, however, after 3 months after transplantation of the non-red cardiomyocyte, we confirmed most of the transplanted cardiomyocytes turn into the which red cardiomyocytes, suggesting the which non-red cardiomyocyte turn into the cell cycle inactive cardiomyocyte 3 months after transplantation. And we also check the morphology of the transplanted cardiomyocyte of the red cardiomyocyte and non-red cardiomyocyte. And we confirmed which non-red cardiomyocyte and red cardiomyocyte show the similar sarcomere morphology and the connexin 43 expression 3 months after transplantation. So, from these results, we concluded cell cycle activity is one of the essential denominator of the regeneration capacity of the iPS-derived cardiomyocytes. So we try to find out a chemical compound which can activate the cell cycle activity of the iPS cell-derived cardiomyocyte. So we used array scan imaging system, and we try to find the hit compound which increases the which green cardiomyocyte. So from more than the 4,000 compounds, we have identified several compounds. Among the hit compound, we focus on the AM80. So, AM80 is a retinoic acid receptor agonist, and we confirmed the treatment with the AM80 increased the percentage of the which green cardiomyocyte from 5% to 16%. And we also confirmed the treatment with the AM80 significantly increase which green cardiomyocyte and reduce the which red cardiomyocyte. And also the EDU assay shows the significant increase of the proliferation capacity by the treatment of the AM80, and also the significant increase of the resulting cardiomyocyte number. So next we transplanted the AM80 treated cardiomyocyte into the infected mouse heart. So we observed a significant increase of the graft by the injection of the AM80 treated cardiomyocytes. So this is the image 3 months after transplantation. So you can appreciate most of the transplanted cardiomyocyte finally turn into the which red cardiomyocyte. So we also confirmed the graft size is significantly increased by the treatment of the AM80, and interestingly, the AM80 treated cardiomyocyte are more prone to be engrafted in the scar compared to the border zone. We also check the cardiac function using the echocardiography. So the injection of the iPS-derived cardiomyocyte significantly improve the cardiac function. So by the decreasing the LV dimension and the increasing the fraction shortening. However, we cannot find any significant difference between the AM80 treated cardiomyocyte and DMSO controlled cardiomyocytes. So there is a discrepancy between the graft size and cardiac function improvement. So we think that's because the human iPS-derived cardiomyocytes cannot couple efficiently with the mouse host myocardium because the mouse beating rate of the mouse heart is more than the 300 or 500. So human iPS-derived cardiomyocytes catch up such a first beating. So so in the case of the transplantation of the mouse heart, the paracrine effect is more focused. So the cardiac improvement of the cardiac function count on the paracrine effect, not the remuscularization effect. So we need more study using large animal model because in large animal model, the improvement of the cardiac function count on remuscularization effect more than paracrine effect. So we compare the gene expression profile of the M80 treated cardiomyocyte, and we confirmed cell cycle and mitosis related gene enriched in M80 treated cardiomyocyte. In contrast, muscle related gene were enriched in the control cardiomyocyte. So we conducted the motif enrichment analysis, and we confirmed the motif related to the retinoic acid receptor, such as RLRA or RLRB, and the expression of the such retinoic acid receptor gene is upregulated by the treatment of the M80. So we conducted a knockdown experiment of the RLRA and RLRB, and we confirmed the knockdown of the RLRA and RLRB eliminated the proliferative effect of the M80. So we try to identify the downstream genes which is robustly affected by the treatment of the knockdown of the such retinoic acid receptors. So we finally pick up the, we find 34 candidate genes. So these genes, among these genes, 6 genes related to the Wnt signaling. So from these results, we think the proliferative effect of the M80 was at least partly caused by the activation of the endogenous canonical Wnt pathway through RLA and RLB. So this is summary. So the cell cycle is a critical factor for efficient engraftment, and AM80 was identified to activate the cell cycle activity in iPS-derived cardiomyocyte, and the retinoic acid signal is related to the cell cycle in cardiomyocyte, and AM80 activates cell cycle activity by activation of the endogenous canonical Wnt pathway through RLRA and RLRB. So that's also, we are grateful to the, all the collaborators. Thank you for your attention.
Okay, we are gonna skip the questions. Let's gonna go to the next speaker. So our next speaker is Dr. Uosaki from GC Medical University, who is gonna talk about cardiomyopathy disease models with mature iPS derived cardiomyocytes.
Thank you, Chair, and thank you, organizers, for giving me this great opportunity to share our recent progress of the cardiomyocyte maturation that they're following up the Yoshida Sensei's work. So, let me see. So, as we already learned that pluripotent stem cell derived cardiomyocytes are quite immature. We cannot compare that one to adult cardiomyocyte, obviously, and it makes very difficult to make a disease model using iPS-derived cardiomyocyte. So last almost 10 years, my focus is how can we make these immature cardiomyocytes mature? And recently, we are successful to make them more mature. So we want to know what kind of phenotype we can observe with this matured patient-derived cardiomyocyte, iPS-derived cardiomyocyte. So I don't think I need to go over the detail of cardiomyocyte maturation, but we know the cardiomyocyte undergo a lot of different changes from morphological, physiological, and metabolical changes. And the something we know is we know those changes happens, but it's kind of qualitative. We cannot tell let's say if we had certain changes, we cannot tell how mature these cardiomyocytes are when we compare to the in vivo cardiomyocyte. So my first project related to cardiomyocyte maturation is to determine the cardiomyocyte maturation quantitatively. So to this end, I examined the transcriptome of mouse heart. So using the GEO microarray data set, I examined, I realized that transcriptome changes pretty much linearly from early embryo, let me see. Yeah, early embryo that showing green to the adult showing red. So this plot prompted me to examine ES-derived cardiomyocyte. So in this case, I use mouse ES-derived cardiomyocyte because these data sets are also mouse data set. So mouse ES cells have about E3.5. So 10 days of cardiomyocyte differentiation gave us the E13.5 if it goes smoothly. And then another 10 days gave us the neonatal cardiomyocyte, and further 10 days should be adolescent cardiomyocyte. But the reality is not, of course. And what we found is this 30 days cardiomyocyte stopped somewhere around late embryonic to neonatal stage. It doesn't go over to adolescent stage. So next question is why they cannot mature. So we performed transcriptome network analysis to identify the potential inhibitors or identify what intrinsic regulators are. So this network analysis idea is simple. If target genes are less expressed, then the center or core transcription factor is supposed to be less active. So using this technique, we identified a number of transcription factors are inactive in pluripotent stem cell-derived cardiomyocyte if we compare to neonate or adult heart. So first, I hypothesized that if we upregulate those transcription factors, or if we activate those transcription factors, perhaps we can make cardiomyocyte mature. To this end, we want to screen the transcription factor, but the microarray is too costly, so we developed the RNA sequence-based method and reperformed the order analysis using RNA sequencing. And to make analysis more simple, we make maturation score calculation, and this score linearly increasing from early embryo to adult. And the good thing of RNA sequence is we can easily compare mouse data set to a human data set. So we can see quite easily we can compare mouse data set and human set. And so using this technique, we first examined 92 transcription factors that we found in our previous data set. So using transducing each transcription factors to mouse stem cell-derived cardiomyocyte and performed and calculate maturation score. Initially, we found the PGC1 alpha beta and the nuclear receptors are top candidates. So in collaboration with Churan Kwon of Johns Hopkins and Sean Murphy, clearly show that when we knock out PGC1 alpha and beta, we can see smaller cardiomyocyte, less mitochondria, and a lot of maturation is disrupted. But when we look back this maturation score, the score is about 60. And the maturation score 60 is about P14 or less. So we can say PGC1 alpha and beta are necessary, but it's not sufficient to make cardiomyocyte mature. And this is my colleague, my previous colleague, Gansik Cho, showed that when we transplanted cardiac progenitor cells to the neonatal rat, then we can make mouse ES-derived cardiomyocyte to fully mature to like, we cannot distinguish the mouse ES-derived cardiomyocyte to adult cardiomyocyte. And we can do the same thing with human iPS-derived cardiomyocyte, and we can clearly see sarcomere shortening of human iPS cardiomyocyte are same as human cardiomyocyte that surgically obtained. And PGC1 alpha and beta is well known that co-receptor for many nuclear receptors. And when we look at our data set, we found a lot of nuclear receptors are inactive in stem cell-derived cardiomyocyte. So we hypothesized that maturation is regulated by extrinsic factor, and perhaps that is hormones and the endogenous nuclear receptors. So we decided to screen the nuclear receptor agonist. So we found 20 nuclear receptor agonists we can purchase. So we screened. The first hit was thyroid hormone, T3, and then we combined to finally we got, in the control condition, we got the maturation score about 40, which is P1 to P4. Makes an triple combination, we got score around 70. That is somewhere between P14 to P28. And when we look at cardiomyocyte, we can clearly see T-tubule throughout the cardiomyocyte. And if we look at the ultrastructure of cardiomyocyte, in the control condition, we cannot, we have sarcomere, but it's very sparse. But in this triple hormone condition, we can see a massive sarcomere and good mitochondria located throughout the cells. So since this is mouse data set, mouse results, so we want to test the same thing in the human cardiomyocyte. So we differentiated human iPS cells toward cardiomyocyte, and we did basically the same screening from 2 and 3. And in this condition, the baseline is very close to fetal. And then the top hit was somewhere between fetal and adult heart. But since we can easily compare the data set to mouse heart, so we compare this score to mouse heart. And in the control condition, we got somewhere between P16 to P1, mouse heart. And then in the triple combination, we got somewhere around P10. So the maturation is a little bit less than mouse cardiomyocyte. So we look at the morphology of cardiomyocyte with treatment. So cells are getting bigger, but it's not rod-shaped like mouse cardiomyocyte. And we look at the calcium handling property, and we found 2 different conditions that looks very good. But in this case, we use that thyroid hormone T3, RXR agonist SR11237, and then DY is a ESR agonist. And 27OHC is a RXR agonist. And for calcium handling, we found this triple combination is better than the other condition. But when we look at mitochondrial activity, then different combination was better. So we might need to combine further to get the best combination. But right now, we have 2 different maturation conditions to make human cardiomyocyte mature somewhere between neonatal cardiomyocyte to adolescent stage. So now we got the relatively mature cardiomyocyte from human iPS cells. So we want to test what kind of phenotype we can get from patient-derived iPS cells. So we decided to develop patient-derived iPS cells. But what kind of disease we should focus? So the first we thought, with this triple combination, we got really nice mitochondria increase can be seen. So we thought probably we can see a good phenotype with mitochondrial cardiomyopathy. And mitochondrial cardiomyopathy is a very devastating disease that almost half of patients dies within 1 year of diagnosis. And there's something we know about mitochondrial cardiomyopathy is about 70% of patients develops hypertrophic cardiomyopathy. And if patient develop HCM with neonatal onset, then pretty much all patients dies quite soon. So we want to test whether we can phenocopy the mitochondrial cardiomyopathy with iPS-derived cardiomyocyte. To this end, we collaborated with Dr. Kei Murayama, the leading pediatric physician in Japan, to study the mitochondrial disease. We developed, so far we developed iPS line from 23 patients with a lot of different mutations from complex 1 through 5 and something related to mitochondrial biogenesis. And we believe that this iPS cohort is the largest in the world so far as I know. So first we differentiated these mitochondrial cardiomyopathy iPS cells toward cardiomyocyte. And our protocol gave us the 10% to about 40% of cells become cardiomyocyte in healthy donor. And we differentiated 68 iPS lines from 23 patients, and relatively similar result we can obtain. It's quite variable, but we can get the cardiomyocyte from all the patients. Next, we purified cardiomyocyte using other associated virus containing cardiac troponin promoter-driven blastogen-resistant gene, so that we can easily purify from any iPS cell lines. So these two pictures are healthy donors, healthy control cardiomyocyte, and this is just 21 days of differentiation. It's quite early stage, but actually what we found is many iPS lines showing the hypertrophy. As you can see, for example, this is attached to duplication. You can see quite big cardiomyocyte that covers the entire field here. And many other lines showing the same. You can see the hypertrophy cardiomyocyte without maturation. And when we look at the calcium handling of those iPS lines, the healthy line can beat and showing the calcium handling property normally. In contrast, this patient-derived iPS line, some lines showing the quite normal looks, but if you look at the hypertrophic cells, then you don't see any calcium oscillation in some case. So we want to know what happens when we mature them. So this is a healthy line again, with two different maturation conditions. As you can see here, the cells looks a little bit rod-shaped. Then this is the ATAT3 deletion line, deletion patient-derived line. And if the baseline is a little bit bigger than the control, and then with maturation condition, you can see cells are bigger and rounded, not rod-shaped. Moreover, when we look at the nuclei, it's a little bit difficult to see here, but this orange and green indicating the multinuclei, more than 3 nuclei in a single cardiomyocyte. So we can observe those multinuclear cardiomyocytes negligible in the healthy line, but if we mature, we observe such weird look cardiomyocyte. And this is not the very reproducible result, but when we look at we found the one cardiomyocyte has almost 20 nuclei in single cells. And when I observe these cells, this weird much nucleated cardiomyocyte are beating. So this is a quick summary. We can get adult-like cardiomyocyte from mouse ES cells. Human cardiomyocyte mature, but it's not adult look-like. And if we matured mitochondrial disease, mitochondrial cardiomyopathy cells, then we got pathological hypertrophy. So I would like to thank all my postdocs and grad students. Actually, Narwin had a poster, but it looks like he already took down. Thank you for listening, and I'm happy to take any questions.
So any question? No? Okay, so it's gonna go with the next speaker. It's Dr. Saito from Nara Medical University. So he's gonna talk about new drugs delivery system for intravenous coronary thrombolysis.
Thank you very much for kind introduction. So I express my sincere thanks to the organizer, especially the Jay and Keiichi Fukuda to invite me. So my presentation is quite different from the other papers. So my paper is not regenerative and not molecular biology, but please listen to my presentation. Okay. So this is my COI. And to begin today's talk, I would like to show this data, which is historical data and reported by the Professor Reimer that show the time-dependent wavefront phenomenon as a mode of MI progression. This study was reported in about 50 years ago. And this data show that the necrotic area extend from subendocardial myocardium to the epicardial myocardium like a wavefront. But this concept was built about a half century ago and Keith Reimer. And this concept lead to recanalization therapy. And this is the guidelines of Japanese Circulation Society that say primary PCI should be performed completely in a STEMI patients within 12 hours after the symptoms onset. However, when 3 hours, when the symptom onset is within 3 hours and the time delayed to perform the primary PCI exceeded 1 hour, fibrinolysis, thrombolysis should be considered. So this is the effect of the primary PCI in the Japanese population. This is the claim database based result. The left show the effect of the PCI on a 24-hour mortality in the left and the 30-day mortality in the right. As you can see clearly in this slide, the PCI is dramatically reduce 24-hour mortality in a male and a female, and also the PCI, primary PCI, reduce mortality of 30-day significantly. And this figure shows the change in the door-to-burn time and the mortality rate in the United States. To the door-to-burn time indicate the yellow was shortened from 83 minutes in 2005 to 67 minutes in 2008. But the 30-day mortality rate indicated in purple remained almost unchanged. This was in somewhat disappointing results. Those results indicate that the total ischemic time, symptom to the balloon time, is more important than the door to balloon time, and the door to balloon time is one component to total ischemic time. Thus, this study concluded that the additional strategy are needed to reduce in-hospital mortality. Furthermore, it seemed that a revolutionary change in the thinking is needed to reduce the mortality rate of the MI, such as starting the treatment in the ambulance to shorten the symptom and balloon time. Therefore, it was necessary to evaluate the usefulness of thrombolytic therapy, although it is currently not widely practiced. Thrombolytic therapy has a great advantage compared to the primary PCI because it does not require special skills. It can be started immediately after the diagnosis, and in some cases even in the ambulance. However, it has serious disadvantages such as a massive bleeding and a low rate of achieving the TIMI-3 recanalization rate compared with a primary PCI. And since the bleeding complication and the improvement of recanalization rate are contradictory, so it seems impossible to ever overcome these two issues with current thrombolytic therapy using TPA alone. Another technique used for the thrombolysis therapy beside TPA is application of ultrasound. Now, many previous studies have proven that the beneficial effect of ultrasound in the thrombolysis. As shown the lower figures, we also reported that ultrasound of 1 megahertz and 0.8 watt square centimeter enhances the thrombolysis in the rabbit arterial occlusion model with HCS-like thrombus. In this context, we want to develop a new drug delivery system for thrombolysis that could be initiated even in the ambulance, and that would ensure the high rate of the reperfusion rate and a low rate of bleeding complications. For these purposes, the new drug delivery system required the following three properties. The first, stress activity, and that means encapsulating the thrombolytic agent to suppress the activity within the systemic circulation. The second is the thrombus targeting properties. That means delivering the encapsulated agent preferentially to the thrombus site. The third is controlled activity, which means releasing the agent at the target area. To enable the development of the DDS just described, we decided to develop nanoparticles that encapsulate the TPA. This is a schematic drawing of the prepare the nanoparticles. The first step is the mix the TPA with a basic gelatin, which is a heat-denatured collagen, and it has affinity to the von-Willebrand factor included in the arterial thrombus. Because the isoelectronic point of the TPA is 4.8, so that it binds to a basic gelatin weakly. And then adding the 5 micromolar of the zinc acetate make the binding stronger and makes it like a nanoparticle with a diameter of 100 nanometer. Furthermore, the ultrasound at 1 megahertz with a force of 1 watt square centimeter reads bounded TPA from a gelatin and restore the activity. Okay, Okay, so that we performed experiments to confirm the strength activity of the nanoparticles and the restoration of activity by the ultrasound and binding to the formalin factor and the in vivo accumulation in the nanoparticle at the thrombus site. As shown in the left figures, the activity of TPA covered with the base gelatin was about 50% less than that of the TPA alone, and it was confirmed that activity was restored to the same level of that of TPS alone by the ultrasound irradiation. Next, as shown in the middle figure, we measure the binding activity of the nanoparticle to the von Willebrand factor containing in the arterial thrombi by the EIA. So as you can see clearly, this particle binds to a gelatin and von Willebrand factor, but TPA alone cannot bind von Willebrand factors. So as you can see in the right panel, the nanoparticle is accumulated in the thrombus site of the mouse model of occlusion model. So that this is confirmed by using a nanoparticle containing the radio-labeled TPA. Next, we attempt to create a pig ACS model while creating the AMI by the stuffing the in vitro created clot into a coronary artery or the ligation of the coronary artery is relatively easy. However, creating in the arterial thrombus at will in the coronary artery require a new technique. For this, we have developed two-step methods. First, we scrape the inside of the left circumflex artery with a PTCA balloon to create an endothelial injury. Next, the distal portion of the endothelial injury is occluded with a balloon to block the blood flow for 30 minutes, which creates a thrombus at the endothelial injury site. Thrombotic occlusion was confirmed by the coronary angiography 30 minutes after the distal balloon was deflated. An ACS model was developed using this method. The thrombus is stained with GP2B3A, and that showed characteristics of a plate-rich arterial thrombus. Next, we generate ultrasound device by the bounding the four probes to generate uniform ultrasound field in any part of the heart. As you can see clearly, the US field is similar in the LV and LAD and RCA and the left circumflex artery. So this field is measured by catheter type oscillometry measurement. So this slide shows the protocol of theoretical experiments. The following, as mentioned in the previous slide, so that we created endothelial injury by balloon, they checked the occlusion 30 minutes later. Then we administered TPA or the nanoparticles transvenously, followed by the angiography every 15 minutes to check the recanalization. To swine was observed for totally 60 minutes. We investigated the effect of the thrombolytic treatment in the three groups. One is the TPA alone group, and the second is the TPA plus ultrasound group, and the third is the nanoparticle and ultrasound group. The dose of TPA is 55,000 units per kilogram, and half dose of the half dose 27.5 thousand international unit. This slide shows the results of the TPA activity over time after the administration of TPA and nanoparticles. The yellow line is the results of the TPA alone, and the green is the result of the TPA plus ultrasound, and the red is a result of nanoparticle plus ultrasound group. The yellow and green and red are the sample from blood from occluded left circumflex artery. The blue is the results of the nanoparticle with ultrasound, but for the comparison, this is the result of blood from femoral artery. In a TPA alone, a TPA plus ultrasound, TPA activity is peaked at 5 minutes after the administration, then declined to about 50% at 5 minutes, and continued to decline with the activity falling at less than 10% at 60 minutes. In a DDS group, nanoparticle plus ultrasound, on the other hand, TPA activity increases slightly immediately before the ultrasound irradiation, but 5 minutes later, ultrasound activity the TPA activity reached its highest value, which was almost the same as the highest value of the TPA alone. Thereafter, the TPA activity decreased more slowly than the TPA alone group. TPA activity is in the femoral artery, which is shown in the blue, reached its highest value 5 minutes after the US ultrasound irradiation, about half of the value of the circumflex artery. In other words, it was confirmed that effect of the TPA was stronger at the circumflex artery and weaker in the systemic circulation. The graph on the right shows the result of the half dose of the TPA on the left, and the highest value of the TPA activity is about half that on the left, but temporal changes are similar. This slide shows the results of the coronary angiography 60 minutes after the start of the treatment. From left to right, the TPA alone, the TPA plus ultrasound, and nanoparticle plus ultrasound. In a TPA group, there is not really canalized at 60 minutes. In the TPA plus US group, the TIMI3 recanalization is almost achieved, but there is an image of the residual thrombus in the coronary artery. In the DDS group, the thrombus is almost completely dissolved, and a good TIMI3 recanalization is observed. This slide shows the semi-quantitative recanalization rate by the 55,000 unit kilogram of TPA over time. And the leftmost figure, the DDS, the over TIMI3 reperfusion was seen in 40% at only the 50 minutes later, and 90% at the 30 minutes after the start of the treatment. While with the TPA and the US, over TIMI3 recanalization was seen in the 40% at the 30 minutes and the 70% at the 60 minutes. With TPA alone, even after the 60 minutes, only the 30% only obtained over TIMI2 reopening. This slide is a half dose, result of a half dose of TPA. As you can see clearly, the DDS reached about 60% of recanalization at the 60 minutes, but TPA plus US group only 10% recanalization at 60 minutes, and the TPA alone could not reopen them. Similarly, we developed nanoparticles, including a TPA for the DDS in acute microinfarction. The plasma TPA activity after the nanoparticle injection was reduced by about 50% compared to that after the TPA injection, and almost fully recovered at a target area after the US application. The rate of the TIMI over 2 was significantly higher in the DDS group than the TPA alone or TPA plus rutasan groups. So conclusion is our new DDS equipped with the properties of the thrombus targeting, stealth activity, and control activity is effective for the high success rate of coronary thrombolysis. I acknowledge that this study was supported by the program for the promotion of the fundamental studies in the health science at the National Institute of Biomedical Innovation. And I acknowledge especially in the Hiroyuki Kawata and Tsunenari Soeda, they create a big experiment. And we thank for Yoshiko Uesigi and Yasuhiko Tabata in Kyoto University to making nanoparticles. And I also thank Kiyotake making the Alloker company who generate a new rutasan device. And I want to give you this important information. So the ICHR World Congress will be held in Nara and then close to the Kyoto in 2025. And please, some of you, please come to the Nara again. So thank you for your attention.
Thank you. I think we have time for 1 or 2 questions, if there are any. Thank you.
Thank you.